follow
Live?
Thursday. We're live. We are live. Thursday, 6:30. I promised I was going to bring this amazing gentleman to your screen. So I hope that you're all sat and waiting to be wowed, because I promise you, you will be. So this is James Hunt. He has given up his time to come and talk to us about OA pain management. And he has a very special interest also into the behavioural aspects of pain and pain management. So please tell us a little bit about yourself so everybody can go, oh my God, he's amazing.
Thank you ever so much for bigging me up. Well, so I started off in general practice. I spent 7 years in mixed practice, then went into small animal practice. During that time, I'd always been very interested in pain management and how we kind of look after animals a bit holistically, I suppose, although that word is a bit loaded. So I did my certificate in anaesthesia, which incorporated pain management. And then I got the opportunity to go and work at Bristol University with Joe Morrell and Louisa Slingsby, who are big names in veterinary anaesthesia and pain management. So that was great, really exciting, and learned lots and lots from them. And then also at Bristol had the opportunity to carry on with a research project, which was looking specifically at dogs with osteoarthritis and how their pain mechanisms changed, and how they became more sensitive to pain. Yeah. And that was with Joe Morrell again and with Duncan Lascelles. So, you know, really top of the game. So, yeah, riding their coattails, I learned lots and lots there. And now I'm working in clinical practice in Somerset, and I work in anaesthesia, so I look after animals under anaesthetic and manage their pain around the time of their operations. But I also see chronic pain cases, so cases with arthritis, cases with sometimes neuropathic pain, so there's a nerve cause for it. I collaborate with the surgeons and the neurologists, specialists that we have in the hospital, so it's sort of a team effort in diagnosing what the pain is.
Team. Amazing. And yeah, really important, because we were just talking before we went live about how both of us just go, oh my God, it's just too much. It's too much to know. And there's overlap into different disciplines, and you need that buddy to go, can you come and have a feel? Because it's very...
That's right. A lot of what we do, because dogs can't talk to us, cats can't talk to us, it's subjective. It's even more subjective than other areas of veterinary medicine where you can measure things. You know, I can't do a blood test to tell you your dog is in pain.
Yeah.
So we rely on interpretation a lot. We rely on behavioural changes to tell us how animals are feeling.
Yeah.
And so if you can get, you know, two heads are better than one. If you can get somebody else to have a look at an animal and say, you know, I think you're completely mad, you're barking up the wrong tree. Or, yes, I agree with you, I think that dog is experiencing pain. It just gives you, I suppose, when we're diagnosing pain and managing pain, because we can't ever be certain, we can't even be certain about it in another human being. We don't know what that person's experiencing. They can tell us how they feel, but we can't experience it. So we need to try and sort of triangulate and get as many points of information as possible to give us confidence in what we're doing.
Yeah, yeah.
And then you get into the whole placebo thing.
Sorry, let's say that. Let's start and just build. Otherwise, people go. Let's go back a little bit. You talk about central sensitization, and I can honestly say that was one of the influences about setting up CAM. Is that, yes, I had been taught it at uni, and I think all vets that listen to this go, yeah, I can remember it somewhere. But I don't think it really took a hold of me. I didn't really put two and two together. And it was only when I kind of got more interested into OA management because of doing a massage course. I did a myotherapy course, and that word started appearing more, and about, you know, hyperalgesia, allodynia. It's like, oh my God, this is so important that people know about this, because there's nothing worse than a dog kind of going, yeah, I know my elbow doesn't look that bad on x-ray, but this is just unbearable. It's the whole side of my body. It affects everything that I do. Every time you brush past, it hurts me. Tell people what central sensitization is, kind of break it down, and then tell us about your research project. PhD.
Right. We'll try. Okay, so our nervous systems are designed to be plastic, so they change depending on the influences that they're subject to. So what can happen is that in painful conditions, your nervous system, your spinal cord and your brain actually upregulate the pain signals, so they exaggerate them. And that ultimately has an evolutionary advantage. If you have got a part of your body that's painful, you need to rest that, and you need to make sure that you're not a target for predators. So it makes sense for your spinal cord and your brain to start saying, all these signals are you know, really, really painful. You need to go and find somewhere to rest. You need to not interact normally. You need to reduce your interaction. You may need to show defensive sort of aggression. So when you start thinking about those kind of evolutionary reasons, it kind of makes sense why we see the changes that we do in animals that have got chronic pain and central sensitization. So what's happening normally in your spinal cord, you've got sort of balances. So you've got descending pathways from your brain stem down to the spine, which actually damp down the pain signals. And it's certainly in people with osteoarthritis and other chronic pain conditions, they've shown that those are less effective. So that the pain from their joints might be at a certain level, but actually by the time it gets to their spinal column, it's registering an increased level of pain. Those pains tend to not respond quite as well to our standard care non-steroidals and things like that you would use for an inflammatory joint pain.
I've got a really good analogy, just so the people who are going, now I'm getting lost. So there's this really good PT physical therapist over in Canada called Laurie Edge Hughes. So I'm trying to get live, so if you listen, mate. So she talks about central sensitization from a physical therapist point of view, and she talks about having the young school kid, you know, the schoolgirl, that whatever you do to them, it goes, oh, that hurts. Oh, that hurts. You're like, it doesn't really hurt. I've only moved your finger. So she's had lots of girls like that she's tried to treat. And she talks about that in her description of central sensitization. So the brain is saying to the injury, you're just a silly little girl, you're not hurting, it's not a problem. But when it becomes centrally sensitized, the brain goes, oh my God, the girl was right, it's painful. And I think that's such a kind of a good way to describe that. You can imagine that, can't you? Somebody that's
definitely.
Really, I've broken a nail, and you're like, it's not a problem. The brain's saying it's not a problem. But then when you become centrally sensitized, oh my God, your finger fell off.
Exactly. Yeah. And so it's a complicated mechanism. There's lots of different sort of pathways involved. So ultimately there's lots of potential targets for treatment, but also there's lots of places that treatment could fall down or not be appropriate. So I think that's what makes managing it so difficult.
So you said central sensitization has a place. You know, we can understand why. So we have peripheral sensitization, we have central sensitization. We know it has a place, but we want it to basically switch off. It's the problem, isn't it?
Yeah.
Do some people experience central sensitization and jobs are done? Once the injury's healed itself, the central sensitization, the peripheral done. But other people and animals, it just doesn't seem to switch off. It seems to get worse. Is that a good way to?
Yeah, it is. So we've each got our own individual susceptibilities and resiliences to pain, and some of that's probably genetic. And so that's going to make us more or less prone to developing these chronic pain conditions. So yeah, some people will suffer horrific injuries and never go on to develop this central sensitization phenomena, this kind of widespread pain. Others will have fairly minor, potentially, injuries, and be left suffering for the rest of their lives, potentially.
Yeah.
There's a brilliant
TED talk. So if anybody goes, what is this they're talking about? 2 places to go and look. So there's a TED talk, and if you type in chronic pain, there's a guy that's talking about a young ballerina that has a bit of a fall and she lands badly on her wrist. But realistically, it's not a serious injury, but it leads to her not being able to use her whole arm. It discolors everything about it is what has just happened. And she centrally sensitized to actually quite a small injury. Months and months of rehabilitation and interventions to bring it back. And that was like, wow, pain is so complex. Another place that people should go and look, if you go onto YouTube and you type chronic pain, there's a professor, I'll do the link below. It's an hour long, and it's a lecture from the University of Philadelphia, I think, and he talks about chronic pain and the history of chronic pain. It's fascinating, and he just kind of makes it all make sense. And he did it for free because he really wanted the patients in his care to understand better. So this really amazingly academic man gave away this information to just say, the world needs to know this. It needs to get out there. What kind of percentage of the OA cases that we see do you think become centrally sensitized?
I guess I'm at the moment seeing quite advanced cases, but actually even in practice, a lot of cases would be quite advanced. I mean, I would say probably 30 to 40%.
Okay. How can you tell? So say we've got, let's use an example. I'm going to pick on someone. Say Rachel Jackson. Hi, Rachel. She goes in and takes her dog who has had elbow dysplasia since it was a young age. And it's now 6 years. It's got quite gross remodeling, restricted range of motion, gait changes. What kind of thing would tell you that that dog is likely to be centrally sensitized?
So the things we look for that are sort of characteristic of central sensitization are extra sensitivity away from the area of inflammation. So we'd expect the elbow is going to be hypersensitive and painful. But if we're seeing that extend sort of down the length of the limb or even into other limbs, the other forelimb, if we are seeing changes like sort of increased anxiety and things like that as well, I think that tends to fit with a sort of upregulation of the certainly the brain side of thing and the cognitive side of things.
Step back a little bit. So when you talk about, so for me, I would be palpating down the leg and I would expect the dog, when I'm feeling the elbow and around the elbow and asking it to move, the dog would be allowed to go, yeah, come on guys, that hurts. But if I'm moving down towards the wrist and the toes, or I'm going up to the shoulder where there's nothing there, but the dog's like, just no, don't touch me there. Whites the eyes, ears back, avoidance. That's what you're kind of describing as pain away from the area?
Yeah, exactly. So it's the kind of secondary hyperalgesia in areas that are distant from the actual site of injury or inflammation. And again, I saw a dog today who seemed to be, so she had hip OA, but really all the way down the back of her legs, down the muscles of the back of her legs, appeared to be hyperalgesic. And I actually got one of the neurologists to come and have a look and make sure it wasn't a nerve pain.
Right.
But I think, between us, we sort of decided it probably was because she's got upregulation of these pain pathways, and we need to try and damp them down now.
Right. So what did you do when you were feeling that dog? Because there's going to be loads of people, some of them are going to be therapists, there's vets, vet nurses, owners following this thinking, oh, I need to go and film my dog as soon as I stop this. First of all, guys, don't panic, because it's very difficult. I will warn you, it's very difficult. But when you were feeling down these dog legs, were you just brushing your fingers across the skin surface and just seeing what the dog's reaction? Were they kind of stepping away, like goose stepping, avoidance, that sort of thing? Or
yes. So initially, yeah, just gentle pressure to sort of brush the skin. So one aspect of central sensitization means that you will experience pain just to a light touch. So it's always useful to gauge. I mean, that's pretty severe. I don't see it very often, but you do sometimes, and probably not so much with arthritis, but with sort of nerve injuries and nerve pain. That's something you certainly can see.
yeah.
So that's always useful to sort of rule out in the first place, and then actually try and palpate each of the muscle bellies, which is something that I learned from attending acupuncture and physio courses. It is a really useful skill, and unfortunately not something I ever learned at vet school.
No.
And it really changes how you assess these patients.
Stops you being a 10-minute consult person, that's for sure.
It is. So yeah, looking for areas of extra sensitivity in the muscles all the way down the legs. I mean, this dog had a sort of the neurologist came, and obviously they do withdrawal reflexes and things, and the dog had a real exaggerated withdrawal reflex as well, which I think could be related to hyperalgesia.
Yeah.
So that's the thing, you're left interpreting all these slightly
really
anomalous things.
In first opinion practice, I guess one of the ways that when Cam goes and does like practice trainings and stuff, we try and help people make this practical. It's lovely knowing about it, and
exactly,
like me that loves knowing about it, but now how do you actually move forward from it?
Yeah.
So the reason I wanted us to talk about central sensitization, which is your area, and maybe if people want us to, we'll go into greater detail. But the reason I wanted you to talk about it was because I don't think OA is given enough of a platform of what a welfare issue it can be. So, only this year has the collaboration with the University of Sydney and the RCVS with Vet Compass really promoted that OA is up there in the top 3 of being a welfare concern because of the severity of the disease, i.e. the severity of the pain and the impact on quality of life, and also the duration. So we're not talking short term, we're talking this is for life. So central sensitization, when I learned about it, it just elevated this disease from being, it's just OA, to, oh my God, this is space science. This is so complicated. And I just think that it would be nice if people can take that away with them and respect that this isn't a simple disease. It's not just what's happening in the joint, it's also what's happening within the nervous system and all the surrounding tissue. OA impacts the whole body. And the more that I learn, the more I realise you can have OA in the stifles, but you've got behavioural problems, you've got compensatory muscular changes, myofascial syndromes, and they're far away from the actual source of the problem.
That's right. And that's what, when I get to spend an hour or an hour and a half seeing these cases, that's kind of what I'm trying to find out. I'm trying to find out how much joint pain there is, how much central sensitization there I think there is. Like you say, whether there's compensatory muscle changes, because they're probably not going to respond well to my traditional analgesics either. And once we've got a bit of a handle on what's contributing to the dog's pain, then we can try and address it. But in terms of the welfare, the other thing that I try and consider is that all these things, so the physical changes, the disability, the behavioural changes, the increased anxiety, the not wanting to interact, they're having an impact on the dog, and they're also having an impact on the bond between the owner and the dog. And ultimately, I need to treat both the dog and I need to look after that bond, because if I'm not preserving that bond, I'm going to find it very difficult for the owner to complete what I'm asking them to do. You know, if I'm giving them a list of instructions saying, "Thou shalt not throw a tennis ball for your dog," but I've not given them an alternative, I'm going to fail.
Yeah.
And I'm going to have failed that dog, because the owner won't listen to what I'm asking them to do, because I've not given them any better alternative.
And that's, again, you've highlighted one of the reasons that CAM and the want and desire behind CAM, the driver of CAM, is that vets, no matter where you work, you can send your owners into this resource to back up what you said in that consult. So if your first opinion, you are time limited, it's a really complicated disease. And when you turn around and go, here's a non-steroidal, I want to see you again, and please stop throwing the tennis ball, the owner's just going to go, but he likes it. I know. Just mean everything's good for you. So hopefully they can come into this world and get a better understanding that amazing people like you also say, please don't throw the tennis ball. Let's take it back.
Sorry. That's where I came from, doing 10-minute consults, and when I qualified, non-steroidals were fairly new on the market.
This is crazy.
And they were the kind of miracle cure, and we believed that because they were anti-inflammatory and they treated this horrible disease, and the dogs felt better with it. We felt that we were doing the absolute best by giving out a non-steroidal and advising some kind of exercise modification. And within 10 minutes, that was the best we could do, but we felt that was adequate. And then obviously the research has expanded, and we've become more and more aware of how these things work, and now we do need to think about all the other facets of it, including muscle pain and central sensitization, and how it's impacting on the dog's cognitive processes as well. Whether they're becoming phobic or
And look, people also talk about when they are enduring pain, they get like a fog, don't they? So their ability to assimilate information and create the correct decision in a timely fashion gets inhibited. So let's go back to the first opinion practice again, because most of the people that will watch this have a first opinion vet, and they go to a practice. It might be 4 or 5 vets. It's a lovely little building in Cheshire. What kind of things could first opinion, in your opinion, do to expand upon the services that are commonly available? I can start the ball rolling. I think that when you go into the consult room, I think it's a real big opportunity for other people of the team who've observed that dog come from the car, be in the waiting room, to potentially give you a heads up. So I know when I'm first opinion, I'm rushed, really rushed. You're back-to-back consults, and you might not have seen the dog walk from the car park and it's walking like, wonky spider, or you might have not seen him get up from a laying position and really struggle to get to their feet. And I do think there's a way that a team approach could give that vet on duty potentially more information. What do you think?
Yeah, definitely. Yeah. I always try and use, a patient assessment questionnaire as well. So we can give those to the owners while they're in the waiting room. I mean, I am absolutely spoiled in that I've got lots and lots of time to spend with people.
Yeah.
But still, you can give them the questionnaire. It's a short, 13 questions or so that the owner can answer fairly simply. And that gives you an indication of how severe the owner is rating the dog's pain. Certainly over the last week, it can, if they're on a treatment, it can give you a heads up whether your treatment's being effective or not.
Yeah.
So that's certainly something you can do before the consult to make your life a bit easier. You can even have... Sorry?
Exactly the same. Email it.
Yeah, email it.
Put it on your practice website so people could actually optionally choose to download it and use it. You know, that's another possibility.
Yeah.
Other things that were included, and I'm going to do it now, in the book, you just happen to write a chapter. Other things that you mentioned, which I think is lovely for first opinion, is the experience in the consult room, you know, giving the dog time, giving them space, allowing them to settle into their environment, making sure that the handling is considered, you know, thinking about how that dog might respond being on the table. Would it be better on the floor? Yeah. Expand on that for followers so that they might be able to put requests into their vet for ways that they would like the consultation to continue.
Yeah, sure. So veterinary practice as a rule are not particularly friendly environments for dogs who have got any mobility issue. We have slippery floors, we've got echoey rooms, you know, they can feel a bit trapped. So yeah, giving them time to acclimatise is really important. Most dogs, when they first, certainly my dogs, most of my dogs, when they get into a new environment, they're going to be tense. All their muscles will tense up. If a stranger comes along and starts flexing their joints and extending their joints, they're just going to look worried, whatever happens.
Yeah. Yeah.
So maybe even if your dog doesn't mind the veterinary environment too much, get there a little bit early so they can settle into things. Slippery floors are the bane of any dog with arthritis. But it might be possible to put a rubber mat or something down on the floor so that...
Yoga mats. Have them rolled up in a basket or in a sterile container, and give the owner the option that they can go, I need this for my dog, thank you for providing it for me. Or even better, reception can plant the seed that something needs to be done by putting the yoga mat and saying your dog needs this. And the owner goes, do I? And your dog had difficulty getting up and laying down then. Did he? I thought it was just getting old. And then that means that the vet can see that the yoga mat's down. They know.
Yeah.
Mavis at reception has spotted one. So there's really good ways that the team can work better together.
Yeah. And I mean, the other thing is that nurses have got so much to offer in terms of, so when I see these dogs, I try and sort out their pain management. I might recommend acupuncture. I might recommend physiotherapy. But also I try and think about how am I going to, if I'm taking something away, if I'm saying don't throw the tennis ball, I think I need to replace that with something else. So that might be teaching them some scent work. It might just be scatter feeding. It might be hiding treats in, you know, a maze or an obstacle course, which isn't too challenging. It might be, you know, I have been known to tell people to start heel work to music, which sounds a bit mad, but actually, if you, obviously not to competitive standard, but if they're, you know, the dog is moving, it's circling, it's keeping the joints and muscles moving and active, and it's also hopefully improving the owner-dog bond.
Absolutely.
I think they need to see their dog succeed. You know, if we're saying...
And this multidisciplinary team that we talked about right at the beginning. So you've got the classical multidisciplinary team in a referral centre, which is the orthopaedic surgeon, the neurologist, you know, the physiotherapy team, the internal medicine, the anaesthesia. We've got quite a classic structure. But that team really, really is way bigger. You know, even down to the groomer is part of the team, because I've had a number of dogs that we're getting somewhere and then they go and have an hour and a half clip on a small table being, you know, yanked free, and just everything waste of time, gone wrong, and you think, oh, for God's sake. So this multidisciplinary team doesn't have boundaries, you know, dog trainers, behaviourists, the local class that you go to. So yeah, think outside the box, because this needs to be done. We need to be doing more.
Yes. Yeah.
So back to your case. So we're still in the first opinion setting. You're not in the ivory tower of a referral centre. You're back in Somerset, small first opinion practice, and you've got this dog that the owner was aware that he had been limping a little bit, and the dog was a classic age, so let's say 9 years old, and it's a Springer Spaniel, working Springer Spaniel. It's been a bit lame in its forelimbs. And he's kind of put off coming to the vet because he just thought the dog was getting old, but eventually decides to do something about it because he's like, nah, it's not going anywhere. And comes in to see you, and the dog is painful, very acutely painful around those elbows, but you found more uncomfortable up towards the shoulders, maybe towards the neck. The dog's kind of really not settling into the consult room, keeps trying to get away from you. And the owner in their history has described that he's not good at shooting anymore. He doesn't like going on the shoot. He gets really flustered by all the noises. What would you, as a first opinion vet, start kind of thinking and trying to incorporate into your plan for that person?
So, yeah, I think, that is a kind of classic case, isn't it? And I think it can be difficult with some owners that do, they expect the dog to slow down as it gets older. It can be difficult to persuade them that actually that's a sign of pain. That dogs are they're such good friends, aren't they? And they will carry on to as much as they can. So I think if the dog's showing him that he doesn't even want to go out on a shoot any longer, that is trying to tell him, actually, I'm suffering here. I'm in quite a lot of discomfort.
Almost catastrophic pain, because most dogs of that ilk, as you say, they'll come back with a broken leg and go, should we go again?
Yeah.
So it's amazing what kind of pain they will tolerate until they get to that point and go,
not doing it anymore. No. We also know that chronic pain or ongoing persistent pain is associated, certainly in people, with anxiety and depression, but in dogs it's been linked with development of noise phobias and things like that. So changes like anxiety also tell us that the dog's welfare is being affected, really. What's happening is that they're getting these pain signals all the time, and their brain is looking for something to associate them with. So, they hear a loud noise and they start to associate a loud noise with being in pain. Or they hear a loud noise and their muscles tense up and they get an acute exacerbation of the pain, which makes it even worse. So I think, it can be difficult to persuade people that the dog is in pain, but because often they will respond very well to a non-steroidal, within a week, then an analgesic trial, you can actually get people to buy into it for a month and say, well, let's assess your dog now. Let's fill in a, assessment questionnaire. Let's try and record how painful he is on his elbows, what his gait's like, and then repeat that in a month's time after the treatment. And often people will come back saying, it's a different dog. I hadn't realized how bad things had got. And we don't, we it's a blind spot for us. Even with our own dogs, we think, is he okay? Or is he a bit stiff? Or, and, you can try a medication, you think,
natural human want there, because I've had it a lot with Luna recently. There's a natural human want to not see what you're seeing, feeling a bit lame in hind limb, and I've been like, no, she's not having pain, no, and you kind of try and pretend it's not there. So when you have conditions that are like intermittently upping and downing, which is OA and all the associated pain that comes with it, it's very easy as a human. It's not your fault to be like, there's nothing there. It's fine.
Not at all.
The fear of going to the vet and saying, there's something, and then finding nothing. A lot of owners say that as well, don't they?
Yeah, exactly. And that's a really important message to get out, is that there is now so much that we can do to improve life for these dogs. And you know, obviously dogs want to run around and chase tennis balls and things like that. And so I think if you're then saying actually your dog's now got a condition which means he can't do that, there's an element where you almost grieve for, you know, what you think the dog ought to be doing. But hopefully we can bring enough new activity to bear.
I've got a bit of a bone about that one because, well, that's a bit of a pun. I've got a bit of a bone about that. Have these classic images of dogs and how they should be, and even in children's little reading books, the dog will always have a ball, and it will always be a cartoon dog, and the ball will have bounced, and it'll be like up there, and it'll have those black little go faster lines.
Yeah.
The dog. So from a very young age, we're convinced that dogs need these activities to be happy. Yeah. We're really lucky. We've got a brilliant behaviourist on our team, so Rebecca Barr, and she's educated all of us, the team, about what makes a dog happy isn't necessarily what we've been conditioned to believe is a sign of happiness. And you know, this grimace and the excited and the wide-eyed and oh, give me the ball is actually frustration. You know, they're in a really heightened, highly aroused state. Doesn't actually mean they're necessarily really happy.
No, that's right. Yeah.
Is couch potato. Happiness is calm and thanks for the time and great for giving me attention.
Yeah, that's right.
How do we get that across to the public? That's
yeah. And I think there's so many things. That's right. There's so many activities now that we can do to cater for a dog that, you know, can't be as athletic as once it was. So I've got a 5-year-old dog who he has behavioural issues. So I started him training to work as a sheepdog, which he, you know, started coming on. He was okay. And then he dislocated a toe. We managed to fix that. But he continued late, you know, it wasn't right. He continued late. He ended up having an MRI and he's actually got lumbosacral disease. So he's got compression of his sciatic nerve, essentially. And I think that's probably why he ended up dislocating his toe. He couldn't feel where his leg was, you know, running at speed.
Yeah.
So he's now had to retire at the age of 5 from doing these, you know, high impact activities. And it is a struggle, you know, as an owner, you feel a sense of loss because they can't do the things that they seem to enjoy and that you feel that they should be doing. Yeah. So it is about trying to develop other activities that the dog can do, and we can see that they're succeeding. So he does, you know, he's got these physio steps that he does step ups on and back feet on and back feet targeting and that kind of thing. Yeah. And, you know, he thinks it's great because he's getting rewarded with treats for doing the right thing, and he's interacting with me. And so we just, like you say, we have to start thinking outside the box when it comes to.
And I think there's so many kind of like, idiosyncrasies in this whole area. It's a really complex disease, but some of the management things are so simple, but it's complex about how the owner could actually change their wishes and their wants. So it's quite simple to stop throwing a ball for a dog that has got shoulder tendinopathies, bilateral elbow dysplasia, huge amounts of myofascial discomfort. But if the ball comes out, they'll go, I will chase that ball because it's really simple to stop that, but it's quite complex to persuade the owner that they should stop it and that it's detrimental to the dog and you won't see it at the time. It's going to be after the event. Anyway, shut up, Hannah. Let's go back to the first opinion situation. So for our owners that are watching this and they've got dogs that have had arthritis diagnosed and they're on an anti-inflammatory and they're comfortable on that for a while, but a few of the things that we're saying are beginning to touch nerves. Pun. They are noticing that the dogs become a bit aversive to people coming into the house. They might feel that there's been some behavioural changes with other dogs being nearby. Maybe they've become a bit more offensive, or maybe they've, hiding back, keeping out of the way. Or they might have found, like the guy I saw today said, oh, he's really funny about his back being touched now, and the dog's problem's actually in the stifle. So he's noticed when he rubs the dog's back, just goes to pat him, the dog's a bit like, get off. If those people are going, wait a minute, this really rings a bell, what should they?
Definitely touch base with their vets. So it's really, as you said, arthritis is a condition that has good days and bad days, and it's really important that we keep reassessing it and keep a handle on where we're going with it. Over time, it's likely to deteriorate, regardless of what we're doing. So we're likely to get more severe disease with time, and we can start seeing all these changes. So the central sensitization, the muscle pain, we can start seeing them at any point, but it becomes more likely the more advanced the disease is. So if a well-managed condition starts to become less well managed, it's time to touch base with the vet and talk about what other things we could be doing, and that might be introducing different drugs. I know Matt was on the other week talking about pharmacotherapy. It might be looking at physio, it might be looking at acupuncture, laser treatment. All those kind of treatments could be right for that individual dog, but it just signals to us that something is happening, something's changed with the condition that we ought to reevaluate then.
Okay. And someone's just said that my sound is quite bad, so sorry about that. I am in Wi-Fi at work, so I don't know why that's being a pain, so I apologise. What sort of things can people look into? So it's not just medication. There are plenty to choose from that we can trial, and that is the word. It is trial. Nothing is a promise. Everything is let's work together and get the right dose and the right combination. But what other things could people potentially look into in addition to the pharmacological approach?
So, I will often use acupuncture in these cases that have got muscle pain. So that seems to, there are muscle relaxant drugs that we can use, which are sometimes helpful, but equally acupuncture seems to be quite effective for that. We've got a really great ACPAT registered physiotherapist local to us. So, I definitely took my dog to her when he was suffering. They have some really great strategies for improving muscle strength and improving mobility. Management strategies at home, around their home, are massively important. So looking out for hazards in our environment and trying to predict them and stop them being a problem. So non-slip matting, blocking off access to stairs where they might trip and slip. I think we understand now that we need to keep exercising these patients, but it's all about the kind of consistency. So they're not doing loads one day and nothing the next day. But also, we expect a lot of dogs because we will load them up in the car, take them off somewhere lovely, let them off the lead, and they go from cold, unwarmed up muscles to going flat out. And that's when
0 to 100, isn't it? Yeah. Something that I always thought, I can't believe I was that stupid, is the comfort for themselves in the car. I recount in my younger years being put in the boot of a car when we were drunk going to another pub, and how absolutely horrendous it was trying to stabilise yourself in not sat in a chair with a seatbelt, being able to visualise where you're going. Your body does so much, automatically. You don't realise you brace this, you twist, you lean, etc. When you're in the boot of the car, I haven't got a clue. do think about these things, because that can be a bit of a make or break. You know, if your dog's not very comfortable and then you put them in a car boot and drive to Dorset for 5 hours, that's likely to end up, you know, ruining the first few days of that dog's holiday.
Yeah.
A couple of questions coming in. After a dog has been diagnosed with OA, should they periodically have or do they need further x-rays and scans to check regarding the progression, or does the vet just evaluate the dog stood in front of them?
That's very dependent on the dog and the situation, I would say. I think I personally think osteoarthritis is such a common disease that it's possible for you to start a dog on treatment without having x-rayed it, just on the basis of your physical examination. And I have that. It's not perfect, because you can be less certain that it's an underlying arthritic condition, but I think it's, you know, an acceptable strategy. Mm-hmm. If you've gotten some x-ray evidence of arthritis in those painful joints, then you can be even more confident that that's the underlying painful condition. And it is really helpful if we can demonstrate what the underlying condition is. So not everything is arthritis, which is where you get into trouble if you haven't done x-rays. In terms of monitoring the progression, I would say it's useful to do if you've noticed a change in the condition. So if the dog's got significantly more lame, because arthritic joints are less, they're more prone to getting sort of infections and things like that. So you can get an acute flare up, which is actually related to an infection of the joint, not just the arthritic condition. So if you get a change, it's certainly worth doing. If things are continuing as expected, I wouldn't necessarily be x-raying, you know, on a regular basis.
And I think that's where we have to be really honest with the situation. You know, we don't have NHSs. We have a dog that is owned by a person that has financial restrictions, time restrictions, physical restrictions. You've got a family at home, a job. So the vet in charge of the case takes everything into consideration. And I know myself that it will also be influenced by what the owner wants or is capable of. And I don't see any harm in me meddling with their pain protocol and saying, if we don't see an improvement within the next 3 to 4 weeks, then I really do need to re-image because something else might have appeared. So it isn't a black and white situation, Jenny. It's very dog dependent. And the only thing that I guess we would advise is have the chat with your vet, and maybe even do it by phone, by email, maybe not trying to condense it into that 10-minute consult, and just make sure that you're singing from the same song sheet, because there's not, you know, one size fits all. Safe painkillers to use long term. Oh, go for it.
So we have got a range now of licensed non-steroidal drugs, which have been shown to be really effective for canine osteoarthritis. The studies that we've got in terms of safety indicate that on the whole they're really well tolerated by dogs. At the minute, we don't have any evidence that any one drug is safer than any other of the licensed non-steroidals. But what anecdotally, you know, those of us that sort of see these cases seem to notice that some will respond to one drug much better than they will respond to another. And we don't really have any way of predicting that at the moment. So it still comes down to doing trial therapies. So if you have tried, you know, a meloxicam or a carprofen or something like that and not seen a great response or not the response that your vet was hoping for, it can be worth trying an alternative one, because some dogs, for whatever individual reason, seem to respond to one but not another.
Yeah, and I'm just going to butt in and add something to that. From a personal perspective, being a first opinion vet, people come to us and they expect us to fix the problem quickly. And you know, no beating around the houses. You know what it is and you treat it and it will get better and jobs are done. So it's very hard for the first opinion vet in the time constraints to also have the caveat, this might work, but this drug might not be the best one and you might have to come back, because you can feel that that person opposite you is losing faith in you, because the guy that they used to see 20 years ago would always say, this will definitely work. So being a modern day vet, dare I say, who is honest about the situation, it can be really difficult to have these chats with owners. And again, another reason CAM was created, so that owners can prepare themselves. So the truth is that there isn't one size that fits all. There is not just one plan that is going to suit every single dog out there. Another quick thing, I'm going to put you on the spot now. You're going to hate me. You've got a dog that comes in, that dog that didn't like going on the shoot anymore, and he was changing laners. Would you choose a supplement over choosing a non-steroidal?
I personally, all I can tell you, if it was my dog, I would choose a non-steroidal.
That's all I was asking.
And the reason for that is I feel that there is more published evidence. Now, yes, you can criticize the evidence because a lot of it is funded by drug companies who have obviously got a product to sell. However, there are, studies that have been published into nutritional supplements, and some of them show very positive results, some of them less so. So I think the evidence there is more equivocal. If money was no issue, I would do both.
Yes.
But
I think also on a time scale, we have more confidence that you're going to get on top of that dog's discomfort quicker. And you alluded to something that kind of heartfelt when you said they're our best friends and they will be with us through thick or thin. So by the time that they come and say, no, I'm sore now, that means they're generally in a pretty decent amount of pain. And it's our oath as a vet. So for any owner watching this that thinks all vets prescribe non-steroidals and that's the only thing in their repertoire, it's not actually the case. Our oath is to look after that animal's, prevent them from suffering. And I know that I'm going to choose something that is going to reduce suffering as quickly as possible, as reliably as possible, and as safely as possible. If money isn't an object, then yes, I would introduce a supplement at the same time. But I will defend that I would choose a non-steroidal and then add adjuncts to it.
Yeah, I think on welfare grounds, exactly as you've said, we've got the most evidence that these are going to work quickly. Now, that doesn't mean that I would just give non-steroidal and that would be it, because once we've got the pain under control, it means that we can look at doing things like physiotherapy that at the moment the dog is too painful to really benefit from. Once we've got his pain under control, we can start doing some more muscle mobilization and things like that. And that may mean that we can rely less on the drugs in the future as time goes on.
Yeah, totally. Whew, that was the tricky bit. We're fine.
Yes.
No one's actually sent us hate mail yet, so we're okay. So let's just move forward a little bit longer because we've only got a few more minutes.
Sure.
I wanted to tackle a topic that we touched upon. It's slightly off tangent, but it's something we've both experienced. It doesn't get talked about a lot, but anticipatory grief. When I asked James to come on, it fell into conversation quite quickly, and I was quite surprised. I won't lie, I was really surprised he came forward with that so quickly. And I thought, well, if you're happy to talk about it, it'd be a really good opportunity because it doesn't get discussed. And I think it's a really big player that is under the surface with preventing owners maybe following a treatment plan, embracing a treatment plan, accepting the stage where they're at, etc. So just if you're happy to talk about how you experienced it.
Yeah, sure. So, I mean, that that's the other benefit of having been around a long time, is that you then get to experience dog ownership. You get to experience caring for a dog. You get to experience caring for a dog that's got a disability, and you get to experience saying goodbye to a dog. So my first dog I adopted in my first practice, and he lived to the age of 16, but probably from the age of 13, I suppose he started developing signs of stiffness and pain and arthritis. And I started him on drugs, and, you know, that was actually before I did very much acupuncture and things like that. But I felt myself distance from him. I knew what was coming. It was still a long way off at that time, but I felt that because I guess because I was scared of losing him, I actually started to distance myself from him. And you know, in hindsight, I think that I probably missed out, because I could have been doing lots of things with him. I obviously wasn't throwing tennis balls for him, but we, you know, we used to go running. I used to take him running, and I used to take him to do this, that, and the other, and that stopped. And I didn't have the skill set at the time to necessarily replace that with great things. So what we've been talking about, the enrichment, the scatter feeding, the scent work, the heel work to music, or whatever. So I felt that I couldn't necessarily engage with him as I had done previously, and it really affected our bond. And so I think that's, you know, it comes from a place of fear. It comes from a place of being afraid to lose this great member of your family. And it's, you know, it's a natural reaction because you're trying to protect yourself, but also I think the dogs can sense that.
Yes, I really do. I think they really do know, and I think the reason I wanted to talk about it is we did a post nearly a year and a half ago, and I was having a particularly bad time, and I decided to talk about it, which was it was almost like coming out, you know, I have anticipatory grief, and the response was insane, and we only had, you know, a few thousand followers at that point, and I think we ended up having like 119 replies within about 48 hours of people going, "Oh my God, I'm glad that you talked about this." So, and I think it really does impact everybody involved, the multidisciplinary team. So we've had people saying, "Oh my goodness, yes, a lot of my clients have this," and that's from massage therapists. It really affects people's ability to make decisions, to stick to the treatment plan. Sometimes it makes people unbelievably difficult to please. You know, we have owners and you're doing everything you can, but it's still not good enough. And you can see that they're just desperate for someone to say, "You've done enough, you're doing okay, go to sleep." You can tick your boxes. With that in mind, that's why we have our community group. So guys, if you're not in Holly's Army already, there is a lovely community group that is there to try and support you through decision making, preparation, grief, discovery, you name it. It's an emotional support network, and we have a lovely group of ambassadors who give up their time to supervise that group for us. So please do go there. So firstly, we're nearly running out of time because I've got you talking for 60 minutes nearly. Is there you want to say, like you think, "Oh my God, if only I could tell 22,000 people this in one hit"?
What would I say? I would say caring for a dog with arthritis is really hard. So well done to everybody that is currently doing that or has done that in the past. And you are still allowed to enjoy your dog. You're allowed to enjoy your dog being a dog. Just because they can't do what they used to do is no reason to stop having that relationship.
Yeah, we're quite proud of it. I think we've broken the buggy taboo.
Yeah,
There's a bit of taboo about dog trolleys, and they're okay for the little dogs. I don't know why, but we've now got this absolute onslaught of owners with large dogs, you know, 30, 40 kilo dogs in dog buggies, and we're going to get t-shirts done, I think. Really funky t-shirts. Right, so I did prepare you about the 10 top tips, didn't I? Or have I put you on the spot now?
I've seen one of these before, so I was slightly prepared.
Good, okay. So we're doing it in turns, and you're going to start with 9, because that means that you end on 1. So I'm going to start with number 10. So that means that yours has got to be amazing at the end.
Oh, okay. Right.
So number 10 for me is more rugs, less drugs, hashtag. It really makes a difference, and it frustrates me that people think it's just a superfluous addition. It's not. It's a game changer. It's part of the box. Number 9.
Mine has to be. So one has to be the most important.
Yeah. Well,
okay.
It's got to be big. It's just got to be big.
Oh, okay. Well, so the first thing I always recommend is weight optimization, because that is the cheapest thing you can do. It is got the biggest effect that you can do. Get the dog to be the right weight with the right amount of muscle. So that might mean doing exercises and things from the physio, but weight optimization.
Perfect. For me, number 8 is really make the most out of your practice. So a lot of owners often say to us, oh, I don't feel that I've got a good rapport with my vet, or I don't see the same vet twice, and all these sort of things. You are paying for the service. So you need to go to the vets and say, well, my dog's got arthritis. I would like to maximise what you guys can give me. Are there weight clinics, nurse clinics? Do you do any dog groups? Can you advise me of people in the area that you'd recommend? What's the chance that I can see the same vet? Have you got a vet that's interested in pain management?
Yep.
Don't kind of come back going, no, I didn't get what I want. Do go there and say, what can you give me? Because I'm sure that they will have services to help you with.
Yes, definitely advocate for your dog.
Yes.
Yeah. I would say, I think all of us that are dealing with these dogs that have got waxing and waning conditions, we need to be prepared for setbacks. They will happen. They'll have a flare up, but don't become anxious about it. Don't get disheartened by it. Have a plan for it. To discuss with your vet what's going to happen if he has a bad day or a couple of bad days.
Yeah, that's a good one. We're trying to, you might actually be able to help us. We want to make what's called a panic tool, so that owners, when they have a panic, because that is what it is, can actually methodically go through like a flow diagram with yes and no, so that they can go, oh, it's okay, I can wait 3 to 5 days, reduce exercise, maybe mess with his meds a bit because the vet and me planned this, and I can move on. A panic tool. Right, number 6 for me. Number 6 is don't forget the little things like interactive feeders, snuffle mats, licky bowls. If you haven't seen them, they're awesome. Distraction, quality of life, brilliant brain juice is so important. It's not just good for your dog, it's good for you, because it is really hard seeing your dog beginning to struggle, but having those pockets of happiness where they're snuffling into a mat is fantastic for you as well. And there is science behind it. There's a lot of reasons that it's a good addition to your treatment plan. So
Definitely. In terms of exercising, I think about warming up before you let them exercise. So that might mean heat packs. It might mean just doing some sits to stands and figure of 8 walks before they get to go off.
So very good. So number 4 for me would definitely be adding a complementary therapy. So I sometimes get annoyed because complementary almost says, oh, you may not, I'll add it as a complement. I think that we really need to term it integrative. And I think there is a lot of skilled paraprofessionals out there that can really add to your treatment plan. And I've definitely changed as a person and as a vet since I did the garden myotherapy course, because I just didn't realise, since that point, I've become, a bit obsessed about this blinking disease. But yeah, there are lots of other additions. Now, we can't advocate for all these people, so you have to be using your wits about you. Make sure that they ask for a referral, a consent form. Make sure they've got suitable qualifications. Make sure that they write records of their treatments. Make sure they converse with your vet. Make sure you see improvement. Ask your vet for a recommendation. Don't just go loan it. But there's some really great people out there that can help you.
Definitely.
Number 3.
3. Oh, heck. I think reevaluate regularly. So at home, you can use, focus on behaviors that your dog enjoys, and how willing or unwilling they are to do them. You can use that to grade, how they're feeling. You can use the questionnaire tools that we talked about at your vets as well to give them a kind of score on how the dog's pain is. So it's a disease that goes up and down, and over time it usually gets worse. But if we're reevaluating fairly regularly, we can predict those things and sort of stop them becoming problems.
Yeah, like it. Number 2 for me is, I'm a bit like you. I missed Holly's first indications of pain. So she had quite a list of problems towards the end. But I'm pretty sure she had nerve root signature signs for cervical disc disease. And by the way, she had a CT and an MRI and they couldn't see anything. It was only with age did it collapse. And I was like, oh. Lumbosacral noise phobia. I wish someone had told me about that earlier. So I think I would like people to have the confidence to talk to other dog owners, and feel that you are allowed and equipped to suggest that slowing down, getting old, always just getting grumpy, may actually be pain related. And I will warn you, some people take offense. There's a defensive aggressive response that you often get. But let's think of the dog. So, this is your dog more years. You're doing it for their sake. And think of the dog. The sooner that we can, identify the signs that there's something going wrong, the quicker we can manage it and the better the quality of life. So talk to your friends and family. Number 1, it's got to be big. It's got to be big.
Well, so I would say, actually, on the subject of talking to friends and family, I think educate the family so everybody in the house is on the same page. So discuss the management of the dog, not chasing tennis balls. Discuss everybody's role, so who's going to give the medication, whose responsibility it is that the dog gets the medication, and involve everybody else in these other strategies that we've got. So develop, teaching the dog new games, teaching the dog to pick out which flower pot the treat is under, or keep playing games with the dog. That's really important.
Yes. And isn't it strange though, because I know as a first opinion vet, when a person arrives with a new pup, I commonly hear them say, I want to just give them the best of everything. So what's the best food? And what's the best bed? And what's the best harness? And you hear that word and you're like, crikey, but when they come in and the older Labrador is wearing the same collar he's had for 5 years, and he's getting on, I'm not going to get him a harness, and you kind of sit there going, that's quite strange, because at that point in their life they've committed so much time to being devoted to us. Sometimes it seems weird that we aren't more devoted to them. So pets at home, I want an old age dog aisle to the puppy aisle, because it doesn't make any sense, does it? There's so much with the senior dogs, and it's just not commercially catered for yet.
That's right. Yeah. It's they're our best friends, and they don't need new collars, but they need us to carry on interacting with them in a way that is positive and fulfills the needs that maybe they're not going to get from running around as they used to when they were younger.
Yeah, perfect. So, Campers, I haven't had any questions in the last few minutes, so that's all great. If you do have questions, then please put them there. I obviously want him to come back because he's amazing. He's like my brother from another mother. So yeah. So if you think that this has been fantastic, then please say yay, and we'll try and get James back at some point in 2020. But apart from that, thank you so much for your time. It's really,
really great talking to you.
Amazing people like you to come and talk to us. So thank you.
Pleasure.
Cool. See you later, guys. We're going to go now.
Bye.